Okay, welcome all who joined us today for our radiology grand rounds on Hindfoot Fractures with Dr. Smitaman. Dr. Smitaman is a board-certified MSK radiologist working as a clinical professor of radiology at University of California, San Diego. Dr. Smitaman pursued his radiology residency at Yale School of Medicine and his MSK fellowship at University of California, San Diego. Dr. Smitaman is also an active member of the Free Clinic Initiative by UCSD School of Medicine for the underserved population. Health for the World team wholeheartedly appreciates your initiatives for the community and welcomes you for today's lecture on hindfoot fractures.
Thank you, Dr. Singh, and thank you, Dr. Rihanna and the Health for the World for having me back this year. And this year, I thought I'd share my what I've learned about hindfoot fractures, and that is talar and calcaneal fractures. So this is our a radiology perspective of some of those injuries. So for those that use Instagram, I post, or I used to post more often, and hopefully I'll get a chance to do this a little bit more. But this is my quick response or QR to that site. Feel free, and I think I have another slide of that later if you miss it. So disclosures, none. So hindfoot fractures account for about, depending on who you read in literature, about 20% or so of foot and ankle fractures, and calcaneal fractures being more common, okay? And these fractures usually result from a high impact axial load, okay? And often seen in polytrauma, at least here in San Diego, okay? And here in San Diego, if you're familiar with geography, we are a border town with Mexico, and our government to try to mitigate illegal immigration, they built a wall about, depending on again who you read, about 400 to 500 foot length between the two countries, okay? And here, just to give you a perspective of how large or how tall the wall used to be, here's an average sized man just repairing a section of the wall, okay? And it used to be about 15 to 17 feet is what I'm told. And you can see here, there's a gap, and he's addressing, the maintenance of this wall. But for those that have followed U.S. politics, a few years back during presidents, they tried to increase the size of the wall or sections of the wall. And here are some prototypes of the wall that our administration had to choose from. But the majority, my understanding, is that this wall, as you can see here, okay, that it's now, I'm told, about 30 to 35 feet tall. And just to provide perspective, as I did in the previous slide, with the man, I provide an American truck, and now you can see how high this wall is. And because of this, the height of this wall, as you can imagine, there are still migrants trying to get into our area, and unfortunately, we see a lot of injuries, okay? And that kind of, one of the things that we've seen are a lot of these hindfoot fractures, and that's how I kind of got interested in this topic, okay? And just to paint a better picture for you, and again, not trying to get political or anything like that, just notice here, okay, this is a recent article published by our traumatologist showing, okay, the spike in the number of our admissions here at UCSD after the wall was increased in height in about 2018 to 2019, and it's increased by multiple folds, as you can see here, almost by like 300% or so, just this spike. And we are set to match or even eclipse that number. And mind you, these are seriously injured patients, and these are patients that and also the mortality is also increased at the scene too, because of the height of the wall. And these are just the people that survive and make it to our hospital system. So a serious issue and humanitarian crisis. Okay, so so that's sort of the background. So to add the next layer, so here at UCSD, we love to drill down and try to really understand the anatomy. And by understanding the anatomy of what we're dealing with, that helps us to understand the pathophysiology and subsequently the imaging and better guide patient management. So that's the sort of the order of the talk this morning. So again, we're going to be talking about hindfoot injuries, and the hindfoot is specifically dealing with the talus and calcaneus, and we'll deal with the two bones in a proximal to distal fashion. So we'll start with the talus, okay? And we as radiologists, we are helpful, or we're important in the workup of these hindfoot fractures, okay? So as I mentioned, the hindfoot, talus and calcaneus, that these two bones are going to basically span the tibio-talar joint to the transverse tarsal joint, as we see here. Hopefully y'all can see my arrow. And these bones together function as rigid but flexible body weight supports, absorbing and transferring loads during walking or bipedal movement, okay, walking and running, everyday daily activities, okay? Now the talus, or AKA the astragalus, is the second of the largest of the 7 tarsal bones. Now, if we look at the talus laterally, as we have drawn here, okay, on this computer rendered image that we created, you can liken it to a Volkswagen Beetle, a car, okay, or a hound or a dog's head, okay, with the dome-shaped body, okay, the stout cylindrical neck that projects anteriorly, medially, and slightly plantarly, ending in a convex head. And now the talus is going to have 7 chondral-line surfaces, allowing articulation with the tibia and fibula superiorly, okay, the navicular anteriorly, and the calcaneus inferiorly. The talar dome, or the trochlea, okay, is wider anteriorly than it is posteriorly, and that confers maximum ankle stability with dorsiflexion of the foot, okay, or ankle. Now, there are 2 talar body processes, okay? There's a larger posterior process, okay, that extends posterior medially, and it consists of medial and lateral tubercles, okay? And that's divided also by a sulcus that allows the flexor hallucis longus, or the FHL tendon, to pass, okay? Now, there's also a triangular lateral process that extends sort of inferolaterally and bears cartilage, as we can see here, okay, superiorly, okay, to articulate with the fibula, okay, and the calcaneus on the superior and inferior aspects, respectively. Now let's flip the talus 180 degrees and look at it from an inferior to superior view, okay? Now along the talus's inferior surface, there are 3 facets, an anterior, middle, and posterior, that articulate with the calcaneus. And together, those comprise the subtalar joint, okay? And that especially that posterior joint, that's the one that we're gonna pay attention to. Now the sulcus tali, okay, and along with the groove of the calcaneus dorsum, which we'll see in a bit, okay, form a tubular tarsal canal that widens laterally into the tarsal sinus. Now, as you can see from these images, cartilage covers roughly about 2/3 of the talus, okay, with relative sparing of the the sulcus tali neck and the posterior process, okay, below the medial malleolus. Now, this is all important because most talar fractures are going to be intra-articular, and that may compromise biomechanics, okay? The other thing to be aware, okay, there are no tendon or muscle attachments of the talus. So it's going to rely on direct extraosseous blood supply through its non-articular surface, thus placing at risk for avascular necrosis or osteonecrosis, okay? Here, okay, just to talk about some of the vascular anatomy, okay, there are variations, but the main ones are going to be three. There are three main arteries, okay, that are supplying the talus, okay. The posterior tibialis, the anterior tibialis, and that is the dorsalis pedis, and the perforating peroneal arteries contribute to the talus's extraosseous supply, okay. Now, the tarsal canal artery, okay, a branch of the posterior tibialis artery, okay, enters the tarsal canal and anastomoses with the tarsal sinus artery, okay, a branch of the lateral tarsal artery itself, right? And all this basically an anastomotic loop, okay, derived from the anterior tibialis and the perforating peroneal arteries, okay? And within the talocalcaneal sulcus, this forms a sort of vascular sling, okay? And this artery is probably arguably the most important, as this feeds most of the talar body, okay? Looking at the talus from a superior to inferior view, okay, we see some of those arteries supplying the talus as well. And again, notice here that sling, okay, along the undersurface, and I try to lighten it here to get that effect that, you know, we're trying to look at it through the bone. But again, that's probably the most important artery supplying the majority of the body. Now, historically, the talar body was thought to receive nearly all of the blood flow in a retrograde manner. However, contemporary, especially radiologic studies, have demonstrated that there is actually concurrent antegrade flow from the posterior tibialis artery via this posterior tibial tubercle artery, and sometimes this can have an anastomosis with the peroneal, the perforating peroneal artery. So something interesting and to be aware of. So why is this all important? Because so talar fractures, okay, account again for about 5% of ankle fractures and about 1 to 2% of all fractures, right? And as I mentioned, result from high energy traumas and usually a constituent of polytraumas, right? So initial imaging, okay, of these Hindfoot fractures obviously is going to involve radiographs, right? But unfortunately, a lot of these talar fractures can be missed in about, depending on who you read, 25, even up to 40% of the time, okay? And moreover, trauma patients, they're going to present in extremis, right? They may not stay still. They may not be cooperative for the imaging examination. So the next, probably the best imaging, if available, is going to be non-contrast CT. And the nice thing about CT is it's able, as we all know, we're able to reformat in any plane after we scan the patient in whatever position that they can handle, okay? And that actually provides additional fracture information not seen radiographically in up to about 90% of patients or so, okay? Now, talar fractures can be divided into 3 regions, okay? A body, a neck, and a head. Now, it's important to differentiate between body fractures because as you can see, these body fractures are going to involve the posterior subtalar joint. Why is that important? This joint transfers about 75% or more of the body's weight, okay? And that's why that's important. And you can imagine too, if you're going to involve the posterior subtalar joint, it's usually going to cut through superiorly to involve the tibiotalar joint. And that is important because it can lead to altered biomechanics and lead to early osteoarthrosis. And that's what we're trying to prevent, okay? So Iannucci actually came along and defined talar neck fractures as those here, typically anterior to the lateral talar process and thus not involving the posterior subtalar joint. So if you have involvement of this posterior subtalar joint, then it's got to be, by definition, according to Iannucci and others, okay, a body fracture. Okay, here in this 3D reformatted images CT, we see that this is a true neck fracture with no involvement or breach of that posterior subtalar joint. So let's dive into some of these fractures, okay, starting with some dome compression fractures, which is actually the most common talar body fracture, okay? Impaction is generally the accepted mechanism of injury, okay, resulting in damage to the articular cartilage and subchondral bone, okay? And these fractures can unfortunately be occult in about 25% or so of cases radiographically. Lateral lesions, okay, tend to be symptomatic, shallow, okay, and wafer shaped, and it typically are thought to occur after inversion injury with or without dorsiflexion, okay. Contrast that with our medial talar dome lesions, okay. These are typically usually less symptomatic, deeper, cup shaped, okay, and result from atraumatic or traumatic plantar flexion, inversion, and lateral rotation, okay? And there's actually been a Burton Hardy classifications of stage 1 through 4, later supplemented by Scranton with the stage 5, okay? But the key is, okay, is to try to differentiate stability. And how do we do that? If there's obviously, if the fragment is displaced, okay, it's unstable, right? But if there's fluid undercutting the lesion, a lot of cysts and sclerosis, what have you, then, or fluid undercuts or contrast undercuts the lesion, then it's, you're going to read that as unstable. And why is that important? Because then you want to go in there, you want to send your surgeon in to go in there and fix that to prevent that early osteoarthrosis, okay? And obviously, displaced, unstable fragments are going to tend to go avascular necrosis and early degeneration. So that's why those typically are going to warrant surgery. Moving right along to some talar body shear fractures. Okay, these are thought to be caused by a hyperdorsiflexion and an axial load of the foot, resulting in these fracture lines that extend typically through the talar dome. Okay. Isolated shear fractures are uncommon, but they can happen in the coronal plane, as we see here, okay? Sagittal or even horizontal, but also notice here in this coronal shear injury, right, how there's involvement of not only the posterior joint, but also the tibiotalar joint, okay? Approximately 20% or so of talar fractures are going to involve the posterior process, okay? And these are thought to be due to direct forced plantar flexion of the foot, resulting in a compression of this posterior process between the talus and, the calcaneus and tibia, or sometimes it can result from direct trauma of the posterior ankle, okay? These fractures, when they involve these facets, okay, here, obviously the lateral with the fibula here and the medial, okay, are going to be called respectively the Shepherd's fracture when it involves the posterior, the lateral tubercle, and Sedell's fractures when it involves the medial tubercle. But again, here, notice here how the flexor hallucis longus tendon sits within its groove, okay? Moving right along to some more talar fractures, now dealing with some lateral process fractures, which account for about 15% of injuries, okay, and about 20% of all talar fractures, okay, talar body fractures. And these have been referred to as the snowboarder's fractures, and it's thought to occur because of an axial load on a dorsiflex and inverted foot, commonly on the involving the board leading foot in snowboarders who fall from trying to land a jump, what have you. And Dr. Hawkins actually classified these lateral process fractures into 3 types, okay? And from a simple to comminuted to chip, okay? And these, but you want to pay attention to these fractures to see whether they involve, again, that posterior talar process, and that if it's intra-articular, to involve that posterior subtalar joint, to mention to our surgeons. Here, showing a couple radiographs. Okay, these radiographically, these injuries or these lateral tail processes can be quite difficult, but I tried to select the best case for this talk. Okay, and we can see what's been called the V sign. Okay, normally you want to see a sharp V comprised by the projection of the lateral talar process. When you see that it's disrupted here, you want to look at your frontal or oblique views of the ankle. Sometimes you can see a little corner defect, but here obviously really a big lateral talar process fracture with obvious involvement sort of medially. So it's this likely involving the posterior subtalar joint and intra-articular involvement. Moving right along to neck fractures, okay? And talar neck fractures, depending on who you read here, account for about 5 to 10% of talar fractures, okay? And again, this neck, this area is vulnerable to injury. If you remember from the original anatomy, those earlier anatomy slides I showed, that shorter cross-sectional area in this region, right? And you also need that dorsal recess and porosity to allow that extra osseous vascular supply with that vascular sling to supply the body, the majority of the body of the talar body, okay? Now, these talar neck fractures, okay, were first described in World War I patients, pilots actually. And that's why you may, if you review the literature, you may hear the term aviator astragalus, okay? And this actually occurred because the foot was axial loaded against the plane's rudder, okay, during a crash landing, okay? Now, automobile accidents and industrial falls or falls from heights for whatever reason usually cause modern talar fractures, okay? And Hawkins also developed the classifications for this along with Canali and Kelly's addition, the type 4. But as we can see here, basically, the higher the grade injury or number injury, Roman numeral injury, the greater the displacement and the more joints are involved. Pretty straightforward, okay? So to provide some examples of lower grade to higher grade lesions, okay, as we can see here from the top left of our image to the bottom right, okay, type 1s to type 4s, we can see, right, non-displaced, okay, fracture here, a type 1, versus obviously a comminuted and really displaced with the involvement of all the articular surface, talonavicular, tibiotalar, posterior subtalar joint, all dislocated and displaced, a higher grade injury. So, and the higher, actually the higher grade Hawkins-Canals classification fractures have been correlated with a risk of avascular necrosis, infection, malunion, and even obviously subsequent osteoarthrosis, okay? So if you know this classification, you're able to provide it, it may help your surgeons. When, as you can see here, patients are reduced, okay, with external fixation, pins, what have you, for subsequent, in anticipation of final osteosynthesis and fixation. We follow our patients here to assess not only the stability and congruency of the fracture reduction, but also to monitor for osteonecrosis, okay? And bones with intact blood supply are typically going to demonstrate disuse osteopenia. And that's reflective, right? Because of intact vessel, right? So there's hyperemia, healing going on. So what is bone going to try to do? It's going to resorb and then try to repair later. So this radiolucent sign, also known as Hawkins sign, so he also has a sign named after him. This indicates intact blood supplies. So hence there's a lower risk of osteonecrosis or avascular necrosis in these patients, okay? Now, the Hawkins sign is typically most evident on your AP views of radiographs, and it may be incomplete. It may also take up to 6 weeks to about 3 months to manifest itself. But its absence is not a sensitive method of diagnosing osteonecrosis, okay? But typically, if this sign is inapparent by about the 12th week, some literature has pointed out that approximately 75% of these patients will develop radiographic signs of avascular necrosis. Now, that being said, even when they develop, these patients develop osteonecrosis related collapse is unpredictable, okay? But it can occur in about 10 to 50% of patients, depending on who you read, okay? So, and furthermore, as many as 50% of patients of cases or cases with radiographic signs of osteonecrosis can be without symptoms. So, moving right along to some higher, even more serious lesions, as we can see here, subtalar dislocations are even rarer, okay? And these account for about 1% of all, or less of all dislocations of the body, right? These injuries are described based on the direction of the peritalar foot's direction, or that is how the remainder of the foot runs relative to the talus, okay? And this is thought to be secondary to a plantar flex foot in inversion or eversion, resulting more commonly in medial, which is 80% of the time, rather than lateral dislocation, okay, which happens at about 17% of the time. Now, anterior and posterior dislocations are even rare, okay? And medial dislocations are thought to be the most common because of this, rather than the lateral, because of the strong lateral malleolar buttress effect upon the rest of the foot, okay? Now, as you can imagine, subtalar dislocations, typically these are going to happen with high energy traumas, but this has also been described in low energy traumas, such as basketball injuries as well. So something to be aware of. And classically, what you'll see as these injuries are reduced, you may see an osteochondral impaction injury at the plantar aspect of the talar head / neck, and sometimes even talar body fractures posterior. So when you see this, you may want to start to look at the talocalcaneal intraosseous ligaments and other surrounding ligaments to try to pick out some of these associated ligamentous injuries with these dislocations that sometimes have been reduced before you get them to imaging. So something to be aware of. Now, the most severe form, okay, where the talus basically extruded here, okay, totally extruded from all its articulations, okay, at the hindfoot and ankle. This is known as luxatio tali totalis, okay. This, as you can imagine, very rare, typically result of a high energy trauma, okay, and accounts for less than 2% or less of all talar injuries. And it's postulated that this, with hyperplantar flexion, okay, and forward dislocation of the foot, okay, and as the foot is adducted or inverted, the talus is rotated and rests anterior to that tibiotalar joint. And as the foot recoils back, okay, the talus is typically extruded anterolaterally, and oftentimes you'll see an anterolateral soft tissue defect with absence of the talus with this luxatio tali totalis. And we have actually tried to, I am told, we actually try to train our front line response or first responders, our EMT, emergency medical technicians, to try to look for the talus or tali at the scene of the accident, because our surgeons try to actually use this talus, even though it's dirty. They'll try to, some surgeons will try to re-sterilize the talus, clean it off, and use it as a spacer to maintain the bone to length, or the leg to length, to prevent soft tissue contractions, what have you, before they do final planning for surgical fixation. So, but unfortunately, oftentimes this is lost at the scene of the injury. Okay, so rare injury, but something you may see rarely, right? So that wraps up the talus. So I'll pause for a moment, just check our time, and any questions on the talus or comments? All right, yeah, we're about the halfway mark. Okay, so sliding, I don't see any questions, but so we'll slide right into more distally and talk briefly about the calcaneus, okay, or the os calcus. This obviously the largest of the 7 tarsal bones, okay, and this is situated at the posterior inferior aspect of the foot, as we know, and this is a firm but elastic foundation supporting the body's weight, okay, very important bone. And in normal gait, the calcaneus withstands basically 2 distinct stressors, okay? Compression, as we see here, with heel strike, okay, for body weight transmission. And later on with combined compression and sagittal plane bending during the heel rise to toe off, as the calcaneus acts as a lever arm for providing or increasing the power of the gastrocnemius soleus mechanism, okay? The calcaneus is also important, okay, because it also makes up the posterior part of the longitudinal arch of the foot, okay, and it helps to maintain that normal lateral column length, okay, and that this is all going to affect adduction and abduction of the mid and forefoot and aids in foot supination for that effective push off during gait, okay? And for those that are unawares, and I always have to remind myself too, the lateral column of the foot is going to consist of the calcaneus, cuboid, and 4th and 5th metatarsals. The medial, okay, column is the remainder, okay? Obviously the medial side with the M1 through M3. Now the calcaneus, let's talk a little bit about the normal anatomy before we get into the pathophysiology and imaging, okay? So let's understand the normal anatomy to help us understand everything else. You can think of the calcaneus, okay, as a rectangular solid, right, with a thin cortical shell enclosing a lot of cancellous bone, okay? It has 6 surfaces and 4 facets, okay? And 3 of the facets, articular facets, on the superior calcaneal surface correspond to the facets of the inferior surface of the talus that I showed earlier, forming that subtalar joint. And these facets, that is the anterior, middle, and posterior, they lie at different angles to the longitudinal axis of the calcaneus, but can be thought of as one functional unit, okay? Now, the mid-third of the calcaneus supports the all-important posterior facet, okay? This is the largest and functionally most important. And this, as I mentioned earlier, bears about 75% of the axial load across the subtalar joint, okay? Now, the posterior facet is separated from the smaller anterior middle facets by the calcaneal sulcus, which forms the inferior margin of the narrow tarsal canal medially, okay, and opens up to that wider tarsal sinus laterally, okay. Let's turn the calcaneus and look at it from a medial to lateral view, okay, and we see here on the medial calcaneal surface, okay, it's obliquely oriented and dominated by the dense subsyntactinum tali, okay, or nurse elbow. And the middle facet lies upon the superior surface of the subsyntactinum tali, okay. The anterior facet is situated more anteriorly upon the anterior calcaneal process, okay. And that's all supported by this calcaneal beak here. Now, the middle and anterior facets can have a variable anatomy, okay? There can be a combined facet, there can be a congruent, and there can be a sort of reniform, if you will, okay? And the most common is going to be this sort of combined with 42% here. Now, the anterior and middle facets are also important, right? they, along with the posterior articular surface of the navicular, this cadaveric image shown here with the NA, that's the proximal navicular surface. That, along with the combined with the plantar calcaneonavicular, or that is the spring ligamentous complex, all this combines together to form the acetabulum pedis, basically forming a cradle or a hammock supporting the talar head. Okay, so important structures at the plantar aspect of that hind foot. Now, a couple more cadaveric or bone images. Okay, here just want to show how the anterior calcaneal surface retains a sort of saddle shape to articulate with the cuboid. And again, also to highlight that dense sustentaculum tali, okay, obliquely projecting from the medial aspect of the calcaneus, supporting that middle facet. Let's turn it to look at the calcaneus from a lateral to medial view, okay? And notice here that the lateral calcaneal surface is relatively flat, okay, except for a subtle sulci, okay, little depressions with often a few millimeter trochlear process or perineal tubercle that basically separates the perineal tendons, allowing the tendons to glide along the surface of the lateral aspect of the calcaneus, okay, with the brevis superiorly and the peroneus longus inferiorly, okay? But what I want to harp here is, and you can sort of feel it right now, right? If everyone can sort of, feel the lateral aspect of your ankle and hind foot, notice that there's very little sparse tissue. There's very tissue along the lateral aspect of the foot, okay, glabreous tissue. So why is that important? Because of the lack or sparsity of tissue along the lateral aspect or around the hind foot, okay, it's important because now, these fractures are at risk for becoming open fractures, okay? And why is that important? Because now if a closed fracture becomes an open fracture with maybe, tissue disruption or overlying soft tissue disruption, or even pressure necrosis because the fractures are not reduced properly before definitive osteosynthesis, you can get pressure necrosis and loss of skin, converting a closed fracture to an open fracture. And my traumatologists don't like that when that happens, because now you have to deal with an open wound and potential infection, making subsequent management more difficult, as you can imagine. So important to try to highlight or for our traumatologists on imaging, but hopefully they also see that clinically, okay? And a few more slides or this on anatomy or external anatomy, that is, okay? Just want to point out here, notice the prominent posterior calcaneal surface where the Achilles tendon, as we know, inserts, okay? There are also two tubercles located inferiorly to transmit the force of body weight. That is the lateral tubercle, which is the origin for the abductor digiti minimi, while there's a more larger medial process of the calcaneal tuberosity, which is also important because that's the origin of the abductor hallucis, the flexor digitorum brevis, but also the plantar fascia, which acts and the plantar fascia is important because that is the truss of the foot, which helps to maintain the longitudinal arch of the foot, okay? That set aside the external anatomy, just a slide about internal anatomy or the internal architecture of the calcaneus. And as I mentioned, internally, the calcaneus is largely cancellous, okay? And there is actually a group out of India that has sectioned and looked at about over 1,000 calcaneal bones. And what they found was there's about 6 trabeculation patterns that can be divided into two or dichotomized into two major compressive and tensile sort of trabeculae, okay? But the important ones are going to be this red one and blue one right there. And these two sort of converge, okay, at this what's been termed the thalamic portion, this thickened area of bone, okay, and that's actually that's an important landmark for our surgeons, because that's also used, because it's such a dense area right around here, okay. It's oftentimes also used as a fixation point for a screw. But what I want to highlight here is this asterisk, okay. There's a relative paucity of trabeculae here, okay, beneath this critical angle of Gisane. So as you can imagine, with these polytrauma patients, high energy trauma patients, the talus is thought to act like a hatchet or an axe, okay, cleaving, okay, at this relatively weak portion of the calcaneus, causing a lot of these calcaneal intra-articular fractures, okay. So an area of sparse architecture, trabeculation between these blue, red, compressive trabeculae and these tensile, or what I've labeled here, these yellow trabecula, internal trabecula of the calcaneus, okay. Now, how does the calcaneus stay connected with the talus? Okay, rounding out some more anatomy. Okay, it's via these strong medial and lateral talocalcaneal ligaments and the talocalcaneal interosseous ligament complex within the tarsal sinus and canal, as we can see here. There's also the dynamic press fit, okay, force created by the flexor hallucis longus tendon as it wraps itself along the undersurface of the subsyntactium tali. So all of these mechanisms help to keep those two bones, or those two hindfoot bones, together, okay. Medially, okay, just showing up close again, okay, where that flexor hallucis longus tendon is going to run underneath that subsyntactium tali. So as you can see here, right, not only are the facets are going to be important, right, but also to understand, okay, that with these calcaneal fractures, you're going to lose calcaneal height, okay, and you're going to increase the width, and then a little bit we're also going to better understand that the length of the calcaneus is going to shorten. And why is that important? Because with ultramorphology of the calcaneus, right, when you change the morphology of the calcaneus, it's going to change its function, or its ability to perform normal biomechanics, right? And again, acting as a lever arm for that powerful soleus gastrocnemius mechanism, okay, with the Achilles tendon insertion. And again, right, these hindfoot fractures, particularly these calcaneal fractures, in modern day, are typically the result of these high energy trauma, acute axial loads upon the heel with abrupt deceleration, either from a fall or motor vehicle accidents, as you can see here. These cartoons with a patient falling, and also here stepping on the brake on the right. Some 3D reformatted images just from the same patient, okay, was able to scan and get both calcanei from, I believe this was an unfortunate case of also a border jumper, okay, but we can see here these comminuted intra-articular fractures of the calcanei, okay, and this is just to remind me, to tell you, to remind us, okay, that these calcaneal injuries, typically polytrauma, and you also want to make sure that they don't have contralateral involvement, as in this case, okay, which can occur in about, I don't know, about 15% to a quarter of patients, okay? But you also want to image or examine at least the patient for ipsilateral lower extremity injuries, but also thoracolumbar injuries, which can happen about 10% of patients, or what's been called the Don Juan fractures, as they jump out of the windows of their lovers' balconies, okay, the Don Juan fractures. I grew up watching Wile E. Coyote and the Roadrunner, okay, and with these hindfoot or calcaneal fractures, Men, as the Wile E. Coyote, are typically going to be affected 5 times more than women. Um, and that's because, as the Wile E. Coyote, these are thought to be work related. And as you can see here, the coyote chasing the roadrunner is unaware that they're about to fall as they have gone past the edge of the cliff here. So can be seen in a lot of industrial related or work related accidents, as the case of the Wile E. Coyote. Now, calcaneal fractures, moving into now that we understand the anatomy, the normal anatomy, let's talk about the pathoanatomy and talk about some imaging. We're going to focus here. You can dichotomize or divide calcaneal fractures into intra and extra-articular. Okay, now we're going to focus on intra-articular for this talk, as I mentioned, but extra-articular can occur with, anterior process fractures or even diabetes with the avulsion fractures at the calcaneal tuberosity posteriorly. But we're going to deal with the intra-articular fractures, or that is involvement of the posterior subtalar joint here. And again, an important joint that confers or transmits 75% of about the load of the body to the through the foot to the floor. Okay. Now, radiographically, there's the Essex-Lopresti classification. Okay. And by CT, there's a Sanders classification that we'll get into a bit. But the Essex-Lopresti divides these intra-articular calcaneal fractures into joint depression types and tongue types, and we'll understand that in a bit. Okay. This slide just to remind us again, but before we start imaging and looking for all these hindfoot fractures, you want to perform the ABCs, okay? Airways, breathing, circulations. You want to make sure that the patient's usually coming into extremis, that they're okay and stabilizing first. Radiographs are going to be the key or initial imaging examination, and here I provide some classically taught angles with Bowler's angles and Jussane angles, what have you. Oftentimes, a lot of people are going to use the Bowler's angle, right? And that is drawn here as taken from the literature. But what I want to highlight, okay, is normal is about 20 to 40 degrees for a normal Bowler's angle. But what I want to emphasize is just because you may have a normal Bowler's angle doesn't mean that you don't have a calcaneal or hindfoot fracture, okay? Look for those fracture lines, look for obscuration of Kager-Spat pattern surrounding soft tissue edema. But if you're in doubt and you may have a non-displaced fracture, you're not sure, obviously try to proceed to CT for further evaluation. CT, go to it, it's great, okay, and our surgeons obviously love it, and because they're able to understand the fracture morphology and planning for their surgery, okay. But here, as we can see, right, with these intra-articular and complex fractures, how the calcaneus is flattened, it loses its height. Okay, and as you can imagine in other slides, and I'll show you in a bit, how it also shortens, but also widens out laterally, okay? And this, again, diminishes that gastrocnemius soleus liver arm, right? Alters the weight-bearing axis and global function of the foot. And ultimately, if it's not fixed, this can predispose the patient to early osteoarthrosis, altered biomechanics, tibiotalar impingement, and even restrict shoe wear. You can imagine that, shoes don't fit, normal shoes don't fit in these patients who may go on to, were treated improperly or go on to malunion, okay, along with osteoarthrosis. So here, this probably one of the key slides for this talk to understand calcaneal fractures, okay? But what I want you to notice, and taken from the literature, notice here that the vertical load or the vertical load axis of the talus, okay, is going to be slightly medial, okay, to that of the calcaneus, so that when there's an axial load, the patient lands from let's say a high, from a height, okay, that talus is going to be driven down into the calcaneus slightly off axis, okay? And as that lateral tail process, or that undersurface of the talus, acts as a as an axe or a cleavage device, okay, it's going to create two main fracture fragments of the calcaneus, okay? That is the sustentacular fragment, or the tuberosity, or the remaining body fragment, and or also known as the anteromedial and posterolateral fragments. But as you can see, okay, as the calcaneus fractures into these two, by this primary fracture line, into two major fracture fragments, how you're going to get proximal override, or proximal, more posterior migration, if you will, of the sustentacular or anteromedial fragment, thus shortening the calcaneus, right? But also widening the calcaneus, okay, as it sort of displaces, and these two fracture fragments sort of override each other, okay? So that's all going to change the biomechanics. And this is important to address not only articular surfaces, but the overall morphology of the calcaneus. So if you sort of think about it, right, if you take one of these squishy balls, okay, and sort of pull it, these pliable, pull it, or even some dough, right, pizza dough, or what have you, right? If you pull it, it sort of changes the shape. So as the calcaneus fractures, it's going to widen, and it's going to shorten, and it's going to flatten. Okay, sort of like this person pulling this blue pliable ball, if you will. Okay. Now let's layer on a couple more things to better understand these intra-articular fractures. Now, depending on how the foot, okay, is inverted or adducted or everted, valgus or abducted, that's going to help to dictate where these primary fracture lines occur. That is, more centrally or medially towards the sustentaculum tali, okay, or laterally towards the lateral aspect of the calcaneus here, okay? And I label these A and C, but this is going to make more sense in a bit with the Sanders classification, okay? Now, depending also not only on how the foot is inverted or everted or valgus or varus, okay, but also how the talus is plantar flex or dorsiflex, along with the pull of the Achilles tendon, okay? If it's sort of plantar flex along with the pull of the Achilles tendon, it's going to create these sort of cleavage, horizontal cleavage plane fractures that exit at about the insertion, or distal to the insertion of the Achilles, right? And with the Achilles and the gastroc and the power of the gastroc and the soleus, it's going to pull this fracture fragment superiorly, creating these tongue-type fractures as described by Essex Lopresti in their original radiographic description, okay? But if the talus is dorsiflex relative to the calcaneus with that axial load, there's a coronal obliquely oriented sort of cleavage plane that creates these joint depression fracture types that exit before reaching, okay, the calcaneal tuberosity, leading to these joint depression types. But both of these fractures are typically intra-articular, with involvement of that all-important posterior subtalar joint. So here, just to provide a nice example of the tongue-type fracture, okay, this accounts for about a quarter of intra-articular fracture. And management of these fractures, these tongue type, is very important, because notice here, okay, subtalar, posterior subtalar joint involvement, that pull, okay, this fracture fragment is pulled up. But what I want you to notice here, and we can feel the back of our hindfoot. Notice again that sparse skin, okay, sparse glabreous skin posteriorly. And you can see how this, if not fixated initially, okay, or reduced initially, this can lead to pressure necrosis. And this closed fracture can become an open fracture. That's why it's important to initially reduce and fix, and then wait for the soft tissues to settle down. And then typically our surgeon will take these patients about a week later for definitive osteosynthesis, as management of other injuries throughout the body are taken care of as well. Okay, so that's a nice tongue type fracture. With these tongue type fractures, see here, okay, you can get involvement of that medial tubercle or medial process of the calcaneal tuberosity. And again, remember, that's the site of origin of the medial or the central cord of the plantar aponeurosis. And remember, that is an important because that plantar fascia is an important structure that maintains the longitudinal arch of the foot. Okay, so important to look for these associated fractures with these tongue type fractures. So this posterior medial essentially avulsion fracture with involvement of the origin of the plantar fascia. Here I show a joint depression type fracture, okay, and arguably we could sort of say it's a forum cruce joint depression or tongue type, okay, but notice what I want to show here, okay, that the posterior subtalar joint is directed inferiorly and sort of rotated upon itself. But along with this fracture, okay, especially these joint depression type fractures, we get these lateral blowout injuries, okay, sort of the lateral wall blows out, okay, again widening the morphology of the calcaneus, affecting the function, okay. But what I want to also point out is with the widening of the calcaneus, okay, the peroneal tendons become lax, okay, and sometimes you can get instability or fracture along the lateral malleolus at the insertion site of the superior peroneal retinaculum, allowing peroneal tendon instability, as we can see here on this soft tissue windowed axial CT image, okay? So if you see a little, typically 1 centimeter, longitudinally oriented ossific fragment or fleck on an AP or oblique view of an ankle radiograph, you want to think about potential, okay, peroneal tendon instability and try to recommend an ultrasound, okay, if you have it available, or as you can see here, a properly windowed CT, you can make this diagnosis. But mind you, right, with CT, okay, it's static imaging, one point in time, so the peroneal tendons may not be necessarily dislocated at the time of CT imaging, in which case that's why our ultrasonographers like ultrasound better, because you know you can circumduct the foot, okay, provoking this peroneal tendon instability if the patient is able to tolerate that provocative maneuver. Okay, so something to think about with peroneal tendon instability, lateral blowout, widening of the calcaneal morphology with these joint depression type fractures. Okay, so as I mentioned earlier, that A and C that you saw, okay, we can see here, right? Now we can sort of understand where that primary fracture line develops, A, B, and C, and that helps us to understand the Sanders classification, okay? And so that's why, so to tie everything together, okay, the Sanders classification, basically by a CT classification, but if you count the number of fractures through the posterior subtalar joint, you can have, you know, 2-part, 3-part, or multiple comminuted. But if it's non-comminuted, okay, for purpose of the literature, if you review it, non-displaced, non-displaced, misspoke. Non-displaced fractures are 2 millimeters or less, okay? So you can have a totally comminuted, multi-fragmented fracture of the calcaneus, but if there's no displacement whatsoever, non-displaced, it's going to be called a Sanders type 1, okay? But here I provide some 2s all the ways to 3s, okay? But you can see here, all you got to do is count the number of fracture fragments. Here 2, you call it a 2. And depending on where that primary fracture line is, okay, if it's lateral, you call it a 2A. If it's more central, okay, think of the C, central, then it's a type 2C. If it's 3-part fractures, then you're dealing with a type 3. If it's more than that and it's displaced, or that is greater than 2 millimeters, then you call it a type 4. Pretty straightforward. Soft tissue blisters are indicative of a severe injury, okay? And as you can imagine here, as you can see here, these serous field blisters and these blood-filled blisters, typically these are going to be readily apparent clinically on clinical exam to our orthopedist, but I do mention them, okay, when I see them as on RCT here in this calcaneal fracture, okay, because this apparently indicates a higher injury with these soft tissue, especially the blood-filled blisters, okay? So I do mention, but as you can imagine, this is also a setup for soft tissue infection and as well, which could complicate management. Our surgeons love, if you're doing at your institution 3D printing, it helps them to manipulate and even practice before and conceptualize the approach to their surgical management, okay? But maybe one day, as in this case here, some people are using total metal arthroplasties or replacements for some of these hindfoot injuries, but maybe one day we'll be able to print out bones for replacement. I don't know if anyone's doing it out there, but as in, I didn't eat the steak, but I found this interesting. Someone printed out a steak, and who knows how it tastes, but maybe something to think about in the future. So with all this study, I created a provisional checklist for myself because we unfortunately see a lot of these border jumpers. But here I created a checklist for myself and my trainings, but I'm happy to pass this on to you all, okay, for those that are interested. Here are my references, okay, and for those that are interested too, we published all this work and our experience in some of these cases last year in this article in Radiographics, so feel free, check it out. And for those that missed it earlier, this is my Instagram account. And with that, thank you so much. I know I went a little bit over, and thank you for your time and attention, and I'll take any comments or questions and concerns.
Thank you, Dr. Smitaman, for the informative and insightful lecture and for sharing your experiences over the years in the practice. I'm sure the lecture was well received by our audience. I do not see any questions in the chat box as of now, but I do have a small question for you, a very quick
Sure.
one. So, with the emerging use of AI in imaging, what are your thoughts on potential uses of these technologies in improving the accuracy and efficiency of diagnosing these easy to miss hindfoot fractures? Do you have any experiences with AI?
Yeah, I'm not some of my colleagues are using AI, but and we do have AI doc at our institution. Not only we're starting to play with it in the musculoskeletal vision, but mostly right now we're using it for brain or head traumas and chest imaging. But yeah, it would be great, especially for triaging of patients and what have you. We are starting to dabble with AI and applications and computer programs, for instance, with scoliosis studies and whatnot. But we have not moved into yet for fracture detection. But yeah, certainly something that I could imagine being great for fracture detection, but particularly for helping to triage patients, detecting, if it's negative, it's negative, we can sort of move on but I hopefully it'll turn out to be a great adjunctive tool. Yeah.
All right, thank you. I see a lot of messages in the chat box and they are really appreciating the lecture. So I
No,
think we are over
thank you.
time.
Appreciate you
Yeah.
all.
So the lecture will be recorded and posted in the Health for the World YouTube channel.
Yeah.
All right, thank you so much. Do you
No
want to say
problem.
anything?
And please feel free. I think my email is also maybe on your website, but you can find me at ucsd.edu, and Yeah, if there's any questions, please feel free. Thank you so much, and be well wherever you are. Be safe.
Thank you so much, Dr. Smitaman.